index cards. Please, if you have a question, write it, and we will have staff circulating it. You can hand the card to, and then she will coordinate the questions at the end. And that will help Dr. Petri get all the way through it, and she'll be happy to take the questions and to make that work. That will make all of this go very smoothly, so thank you.
Because this is the second year we've had this program and this turnaround auditorium, so it'll be convenient for everyone who comes to see me. Now, what I'm going to start out with today is actually a quote from President Kennedy. Remember when he said, "That's not what your country can do for you, but what you can do for your country"? Well, I'm here to thank you, because all those times I asked you to help with research, and you said yes, it's made a real difference. So all the things I'm going to teach you this morning were learned because of you. So let's start with what causes SMA. And I know you want to know about this because you're worried your children will have it. But only 2% of children get lupus when a parent has it. So this isn't a genetic disease the way sickle cell or cystic fibrosis can be. Instead, what happens is that there are genes that cause susceptibility to lupus, but also susceptibility to other autoimmune diseases. Many of you have more than one autoimmune disease. Some of you have lupus plus Sjogren's or lupus plus hypothyroidism. You wonder, why do I have to have more than one? It's this genetic susceptibility. So for the causation of lupus, 2/3 is due to genetic susceptibility. And how is this learned? This is called a Manhattan plot. Can you guess why? It looks like skyscrapers in New York City. But when you see a peak, that tells you that that's one of the genes that leads to susceptibility of lupus. And many of you in the audience who signed up for that University of Alabama study, this is where this knowledge came from. So most of the major genes that lead to susceptibility of lupus have been discovered thanks to you. Now, there are a few men in the audience with lupus, and you must always feel very lonely, right? Because 90% of people with lupus are women. So, what happens when a man gets lupus? It's really strange. Lupus is worse in men than in women. And it's worse in 2 important ways. Right down here where you see renal failure, there's a 2.8-fold increase in renal failure in men with lupus. And heart attacks, a 3-fold increase. So I actually worry the most about my male patients because they are destined to a worse course unless we intervene early. So how are we going to intervene to prevent kidney failure? Check the urine protein at every visit. For every complication in lupus, if we detect it's trying to happen, we can stop it. And how are we going to prevent a myocardial infarction? We're going to keep the blood pressure normal, the cholesterol normal, we're all going to exercise. So these messages are true for everyone, but they're particularly true for all the men in the audience. And how do we learn this? All my male lupus patients said yes when we asked if we keep all your information in the Hopkins Lupus Code. These are the kinds of information that doctors everywhere who treat lupus need to know. Now, if lupus is 2/3 genetic susceptibility, what is the other third? It's things in the environment. And everyone here knows that ultraviolet light is one of the risk factors for lupus. But there are many other environmental triggers. What is the one antibiotic that I always ask you not to take? Bactrim, right, trimethoprim sulfate. Did you know that it was a lady rheumatologist in Boston named Marion Ropes who discovered that back in 1950? And we still don't know why. At least we know the fact. Smoking is a risk factor for getting lupus, but if you continue to smoke when you have lupus, there's a particular organ manifestation that's awful. It's called discoid lupus. That's the worst kind of skin lupus because it leads to terrible scars which can turn white or dark on the face and the arms, and it can cause permanent loss of hair. So I always urge everyone, stop smoking for so many good reasons, right? Emphysema, cancer, but stop because of lupus. In particular, there's one lupus medicine that doesn't work as well if people smoke. What medicine is that? It's Plaquenil, hydroxychloroquine. So if you smoke, I'm always begging you to find that willpower to stop, because hydroxychloroquine, Plaquenil, is the most important medicine we have for lupus. Now, it turns out that infections can also be one of the environmental triggers. And it turns out the infection that has been best studied is mono. Here's what we all had mono in childhood. You're right, 90% of people do. But when you're genetically susceptible to lupus, the immune system doesn't handle mono as well. And there may still be a little bit of that EB virus lurking around in your immune system. Now, it turns out that lupus is much more common now than it ever was in the past. And that's not just true of lupus, it's true of all the autoimmune diseases. So, what has happened to lead to this great increase in autoimmune disease? We think it's things that we have poisoned our environment with. And so actually the government proved that silica, mercury, and pesticides are risk factors for lupus. So unfortunately, lupus isn't going to go away anytime soon. In fact, there are going to be more and more people with lupus. Now, how do doctors know you have lupus? I know many of you are frustrated because it took a while for anybody to reach the diagnosis. On average, people have symptoms and signs for 1.5 years before a doctor makes the diagnosis. So what was the problem? These are the classification criteria the doctors use, and the person has to have 4 before the doctor can be definitive and say, yes, this is lupus. These are from the early 1980s. Isn't that incredible? Because believe me, science has moved forward, so has clinical medicine. Every single one of you who said, yes, I'll sign up for the AROSE study, helped to make the new criteria which were published this year. And by the way, the Lupus Foundation helped with the cost of this study. So now doctors around the world are learning a better, modern way to classify lupus. We still say that 4 things have to happen to that person, but one thing must be a clinical manifestation and one thing must be one of the lupus autoantibodies. But we made an exception. If someone has lupus kidney disease, that's it. Biopsy shows lupus, that person is classified as lupus, even if nothing else has happened to them. Now, this is the list of the clinical criteria. It's much broader than what we had from 1982. Some of you have some of these rare rashes. There's one called subacute cutaneous lupus that was never counted before. Many things that happen in the brain weren't counted before. They've all now been added. The low blood counts, which so many of you have, they used to all be grouped under one criterion. Now we split them into 3 to make it clear to doctors that each one individually counts. Now everyone here knows about the ANA because about 96% of you who had the positive ANA is one of the clues. But it turns out it's the other autoantibodies that are more specific for lupus. Our problem is 20% of normal women have a positive ANA. So anti-DNA is one of the specific antibodies. Anti-Smith, it's actually named after the patient in whom it was first discovered. That was, I guess, pre-HIPAA. And then, you remember the anti-phospholipid antibodies? Why are they so important? Because they increase the risk of blood clots and miscarriage. They are now all included in the new criteria for lupus. And low complement, which can can show an increased risk of having a flare or having kidney disease wasn't even included in the old criteria. Now it is. And this is named after a doctor, Dr. Cruz, but it's a lupus antibody against red blood cells, and it is common in lupus and occasionally can cause a very low red blood count called hemolytic anemia. So every time I lecture to doctors, the first thing I teach them are the new criteria, so they'll use them. They are more sensitive than the old one. That means they will pick up people with lupus definitively sooner in their course of illness. Now, some other wonderful things have been learned. And I want to tell you that soon in the United States, we will have a new lupus antibody test called anti-C1q. How did we discover this was important? Remember how I stored your blood in the research freezer? We sent it to Sweden, where they do this assay. And we're able to prove that people with lupus who have the anti-C1q antibody are at much greater risk of developing kidney lupus. Can you see that of the people who have anti-C1q, over 45% will get kidney lupus, versus only 19% who don't have it. This antibody is going to change how people decide who's at risk for kidney lupus. And again, it's because of your health. But we went even further. So anti-C1q means that there's a greater risk of kidney lupus. What if you already have kidney lupus? Would this antibody tell us how active it is? Because you know right now I just measure your urine protein to creatinine ratio. But the protein can sometimes stay up when there's scarring in the kidney. It doesn't always mean that the lupus is still active. And we hate to keep doing kidney biopsies. So we sent your blood to a laboratory in San Diego to do this study. And we're able to prove that anti-C1q in the blood does help to predict how active kidney lupus is. So again, storing your blood in the freezer, it's really important. Can you imagine how we felt during the hurricane? I was sending people to check on the freezers all the time. Now, so many of you suffer from chronic pain. I know you do. I do listen when you tell me about your pain. But what I want to tell you is that lupus is not a pain disease. Lupus is an inflammation disease. So when you have pain, I have to start asking other questions because the pain is likely not from active lupus. Now, the pain could be from other things that happen to anybody, like osteoarthritis, degenerative arthritis, or it could be a prednisone complication, which is called avascular necrosis, when it happens in the hips, knees, and shoulders. But the reason we started out with Tai Chi is that a whopping 30% of people with lupus also have fibromyalgia. It is the major cause of chronic pain in people with lupus. Now, this is so unfair because only 3% of the general population have fibromyalgia. So why does it have to be 10 times more common in lupus? We don't know. But we do know how to help you control the fibromyalgia pain. Tai Chi was scientifically studied in Boston. The rheumatologist there is named Timothy McAlinden, and he published a clinical trial of Tai Chi which proved that it can reduce chronic fibromyalgia pain by 50%. So for those of you who suffer with fibromyalgia, this is my message to you. The FDA-approved medicines, of course you can use them, but they all have side effects. And it turns out they don't work nearly as well as Tai Chi, which, because it is natural, really is completely safe. And I recommend to you the Tai Chi for arthritis tape, because it's a simple Tai Chi program. Now, I hope this morning you realize you don't have to be afraid about Tai Chi. We can all do Tai Chi. Now, I am known for having sound bites that are really inflammatory. because when you come with the prednisone complications, I feel for you. So I tell doctors that prednisone is the problem, but I go further. I tell them that the P in prednisone stands for poison. And I want to tell you how strong our data are. And the R here, remember that includes everyone in this room, because how can I prove to doctors that prednisone is poison? It's because you allow us to include all your clinical data in the Hopkins Lupus Program database. So first of all, prednisone increases cardiovascular risk factors. It increases cholesterol and blood pressure and weight. Of course, you know it can also lead to diabetes. Now, hydroxychloroquine, my favorite medicine, it turns out it does reduce cholesterol. It can just about balance what a tiny dose of prednisone may do. But hydroxychloroquine can't help the weight gain and the blood pressure. So cardiovascular disease turns out to be the major cause of death after the first 5 years of lupus. We call it accelerated atherosclerosis because women with lupus start to have heart attacks 20 years before other women. So prednisone increases the risk factors for heart attacks. A whopping 50% of the Hopkins patients, that's you, have at least one organ that has been permanently damaged. The most common organ to be damaged is actually musculoskeletal. I'm sorry something's going wrong with the slides, but it's 25% at the top. That musculoskeletal damage is osteoporotic fractures, which are due to prednisone, and avascular necrosis of bone, which is the permanent damage to hips, knees, and shoulders. That means people will later have to have a joint replacement. So how much prednisone is allowed? Well, in fact, I redefined for doctors that we should not have anybody with lupus on more than 6 milligrams. Because the minute you get to 6 milligrams, there is a 50% increase in permanent organ damage. Now, what if you have to be above 18? Permanent organ damage just went up 2.5-fold. So I am always trying to reduce your prednisone or to limit your prednisone, but I promise I do listen. When you tell me that you need a low dose because otherwise you're going to have a life, I listen and I allow it. But can you understand how if we're ever going to be successful in lupus, we're going to have to find a safe substitute for prednisone. Now, how did we approach this? Many of you were in this study. When someone had a flare, we decided we would never permanently increase the prednisone. We would treat the flare with a triamcinolone injection in the buttock. Everybody remembers the one and only side effect? A dimple in the bottom. Has no other steroid side effects. Or a mineral dose pack for 1 week. And then we looked at how people were doing 1 day after we started therapy. Almost 70% of people with a triamcinolone injection were feeling much better, versus almost 42% with the mineral dose pack. So if you're able to come to see me when you have a flare, of course I prefer this one. But if you can't come to see me, I'll call in the mineral dose pack. Now we're only allowed to do this once every 3 months. If we do it more often than that, there can be steroid side effects. Now, what about NSAIDs? Those are things like ibuprofen, naproxen. It turns out that in the general population, there's now a warning that chronic use of NSAIDs may increase later cardiovascular disease. So if you buy Advil early, the warning's actually there. You'd never know it though, because it's in such fine print that nobody can find it. But it turns out that chronic use of NSAIDs also increases cardiovascular disease when you have lupus. So again, if you need that NSAID, because otherwise you can't tolerate the pain, then of course I'm going to allow it. But I want you to understand this balance. You and I will It reduces bad cholesterol. It reduces clots like strokes and heart attacks. In 2 studies, it improves survival. And we prove, meaning we, everyone in the room, that being on hydroxychloroquine means that there'll be a better response to mycophenolate subset if you have kidney lupus. Are there any risks to hydroxychloroquine during the first 5 years? No. After 5 years, the risk is only 1 out of 5,000 of having retina deposits. That one person will never be harmed because the eye doctor detects the retinal deposit before they have any symptoms in their eyes or any later problems. I can't tell you anything else that's as safe as this. It's so safe, it's allowed in pregnancy. But I want to tell you what happened in Paris. Natalie Costa-Bellett runs the lupus clinic in Paris. And she looked at just the patients who were so sick with lupus that they had to be in the hospital. And she discovered that 50% had 0 plaquenil blood level. 0. And then they weren't taking it at all. Because the blood level measures how much you've taken over the last month. It is so important that we all adhere to the medications that are essential in lupus. So I want you to have a good system to remember. And that's why I love smartphones. See, I decided that God invented smartphones for the alarm feature. So please set the cell phone alarm to go off to remind you when you need to take your medications. Do you think doctors remember to take all our medications? No, of course not. So I understand, and I want to help you adhere. Remember, this is the most important medicine. Now, many of you in the audience have kidney disease. So if you're Caucasian, there's a 50% chance it will happen to you. If you're African American, there's a 75% chance. We are so much better at picking this up early. Do you remember that urine protein to creatinine ratio that we do at every single visit? That's the best way to pick it up early. Remember, we can prevent renal failure if we pick up kidney lupus early and treat it correctly. But we do much more. And this we learned from our colleagues in the kidney field, nephrologists. They have shown in diabetic kidney disease